Welcome to Adapt NCLEX and welcome to the endocrine unit, endocrine crash course. If you walk through this hallway with me for the next few minutes, you will never miss any endocrine questions again. Every room, you will see a patient. Every patient teaches you exactly endocrine concept the NCLEX love to ask. Diabetes emergency, thyroid storm, Addison crisis, SIDH, DI, pharmacology. Let's take a ride into the endocrine unit. This is your endocrine crash course. First thing, we're going to walk through each room, like in the case form, to help you understand endocrine concept. And as usual, Adapt NCLEX way, we're going to talk about each of them. So imagine you start walking in the floor of the endocrine and your first patient, room 1. What do you see? This is what the patient is complaining. The patient said, I lost what? Weight, even though I'm eating. That's the problem. I've eaten everything possible under the sun, even though I have been eating everything. What do you think is going on with this patient? They told me I cannot make insulin, so no insulin. And I will need insulin for life. I'm very young. I'm about 15 years old. And they said there's an autoimmune associated with my condition. What do you think is going on with this patient? What is my chief complaint? Well, I've been drinking a lot. So polyuria, because I'm peeing a lot. And I'm drinking a lot because I'm thirsty. And I've been eating a lot. You remember this? Polyuria, polydipsia, and what? Polyphagia. What do you think is going on with this patient? This is type 1 diabetes. Specific, this is type 1 diabetes. Specific condition, this is what the NCLEX is going to ask you. The next room that you walk to is the same patient. They're sharing. In the same room, there's another patient. The patient said, I feel tired all the time. Why? I have blurred vision. They said my insulin is not working, even though I have. So I have insulin resistance, right? And then this happened because they said my insulin is ineffective. I'm what? 45 years old. And I need to manage this condition with diet. That's what they're telling me. But I may need some oral medication in addition to insulin. What do you think? This is not autoimmune. This is what we call type 2 diabetes. That is the difference you should pay attention to. And this is what the NCLEX is going to ask you. Now, what is the other things you should pay attention regarding this condition? Well, no matter the type, our goal, the doctor said, our goal for each of us is hemoglobin, what? A1C less than 7. Watch for this for the NCLEX. And then they talked to us about sick day rule. What does that mean? The doctor said, well, even if I'm sick, I should stay on my insulin. And I should increase my fluid intake. I should check my glucose more frequently. And I should check my urine for ketones. And I should call my doctor if this is happening. I feel dehydrated. Those are the sick rules. And how do I measure my sugar? Every 3 hours, constant. That's what the NCLEX is going to ask you. Now, the doctor is teaching us something. They said, well, sometimes I need to pay attention to certain things. If I see it, I should worry about. If my skin is cold, I look clammy, I have tachycardia, right? There's a problem. I should take what? Or a little bit confused. I should take some candy because I'm what? Hypoglycemic. These are classic hypoglycemic symptoms. Pay attention. So this patient is hypoglycemic. Watch for that. That's what the NCLEX will ask you about this patient. And the last one, he said, well, if I feel really hot and dry, right? I feel hot and dry, most likely my sugar is too high. Major signs and symptoms of hyperglycemia. There may be other ones, but these are clues telling you the patient is either hypoglycemic or hyperglycemic. Pay attention to that. And that's your patient room 1. These are 2 patients. Diabetes patient, they have what? Type 1 diabetes, type 2 diabetes, the difference between them, and what you need to teach them regarding this condition. Room 1. Are you ready to go to the next room? How are you doing? Let's go to the next room. And we pick a blue one. Next room, the patient, what does the patient say? Hey, we both are in because we have a several condition. So the patients, what does the patient say? The patient that you discharge, both of them, they came back because they have emergencies. So 2 emergencies. 2 emergencies for the same patient. What is going on with them? Figure out what is going on with them. 1, the type 1 diabetes, what did he say? He said he smelled like fruity, right? Fruity smell. And what is it? He's breathing deep and deep breathing, right? He has Cushing breathing. And what is the problem? When we check the sugar, right, his glucose is what? Almost like 240, 250. Let's say 250. It's between 250 to 300 range or 400 range. And he looked really dehydrated. Signs of dehydration, dry mucous memory, right? He's a little bit hypotensive. All these things is very worrisome. And when you check the urine, there is ketones in the urine. And when you draw the lab, the blood, what? The pH is what? What is the pH? What do you expect? pH is less than 7.4, and bicarbonate is what? Less than 18. This is what? Less than 18. Think about it. The second patient that you discharge is the type 2 diabetes patient. And what did he tell you? He is so severely dehydrated. He's more severely dehydrated. He look obtunded, right? More confused. His sugar is over 600. But there's no ketones in the urine, right? And you check the pH, pH is 7.4. And then bicarb is normal. It's normal. That means it's greater than 18. What do you think is going on with this patient? 2 patients that you discharge. One is type 1, the other one is type 2. You send them home, they come back now with these symptoms. These patients, they have conditions we have to figure out. What do you think is going on? Put down in the comment and say, I know this. 2 emergencies, hashtag, and let me know what do you think. But this is the way they are. Type 1, the first patient, this patient has DKA. And the second patient, type 2, has what? HHS. This is hyperglycemic symptoms. These 2 things is very worrisome. Those are the 2 emergencies that you have to worry about diabetes. One is DKA, diabetic ketoacidosis. This is diabetes. That's why you have glucose of 250. Ketoacidosis, you have ketone, and the acidosis pH is less than 7.4. This is osmolar hyperglycemic state. That is HHS. Why? There's no DKA, and therefore pH is normal, bicarb is normal, but what? Hyperglycemic, the glucose is greater than 600. What is your management of DKA? The first thing you should do is fluid. Once again, fluid. Another one, fluid. Don't worry about their potassium. Their potassium will be high. But don't worry, when you give them insulin, it's going to take care of it. If I check potassium in the type 1 diabetes, who has DKA is going to be high. But what is the problem? Number one, fluid, followed by what? Insulin. And then you can watch what is going to happen. The insulin is going to drop their glucose, and you're going to drop their potassium. When the glucose is almost close to 250, less than 250, don't wait. That's when you start to give them glucose to help them. Otherwise, they will be hypoglycemic, and you start to replace their potassium because their potassium will continue to drop. So this is very, very important. What do you do with the type 2, which has HHS? Same thing, except what? Nothing different. Pay attention. Same thing. Fluids, followed by insulin, followed by what? Potassium and glucose replacement. When you start replacing potassium, when it's less than 5, that's when you start replacing them. These are ways to manage this condition. Very, very important. This is the easy way I can explain to you type 1, type 2, and a DKA versus HHS in the very straightforward, simple way to master your content. That is what they're going to ask you. Pay attention and replace them and monitor. Pay attention and know how to distinguish between the two. Now, you went to another room. This is your room 3. What do we have in there? You walk into the room and what? The thermostat is what? On. You see, it's on the wall. And what did the patient say? The temperature was fine, but the patient said, well, one side is cold and one side is hot. What is going on? 2 people, right? Same room. One said the thermostat is on. The other one said, it's too cold. The other one said, it's too warm. What is going on? And one of them saying, hey, I've been gaining weight and I feel cold, even though it's warm, right? They check their heart rate, very low, bradycardia. And the patient said, I'm tired all the time. What do you think is going on with that patient? The next one, what did they say? Well, they said, well, I've been losing weight rather. And the heat is killing me in this room. Heat intolerance. It's too hot, okay? And the other guy's heart rate is high and he's very anxious. He needs to get out of the room because it's too hot. What do you think is going on? One of them has what we call hypothyroid. This guy is hypothyroid. Everything's going down except the weight. You see, weight going up, except everything is going down. This guy has what? Hyperthyroid. Everything is what? Going up except the weight. The weight goes down, but anything you can think of is going up. Therefore, don't memorize them. The key thing is everything going up except the weight, or everything going down except the weight. If everything goes down except the weight, is hypothyroid. If everything goes up except what the weight, is hyperthyroid. What are the emergencies you should worry about these 2 people? Well, this patient will come in, if you don't treat it, they will come in, is something we call mesodermal coma. That is emergency. That means severe form of what? Hypothyroidism. This patient will be confused, will be in shock, need to be in the ICU, and you have to monitor them with IV medication. That's the major side effect. And the pharmacology for this is IV levothyroxine. Pay attention to that. Watch for that, 19-PO. So that's the major side effect and the major condition if you don't treat it. This guy, if you don't treat it, that's the hypothyroid, will come in with what? Thyroid storm. Or they have surgery, they'll come in at thyroid storm. Everything will be high in the severe form. They will have fever, hypertension, all the signs and symptoms, palpitation, tachycardia, heat intolerance, and day 2, they will be in the mood of pending to die. And you have to do them, block the effect of levothyroxine. And this is where you give them different medication. We'll talk about the thyroid medication. That is where you put the thyroid hormone down or methamiozole. This will block the effect of the thyroid. These are the crash course. This video, when you watch it, you don't need any video to watch. But these are little things I want you to know that if you know them, you know everything about what? Endocrine. You don't have to know so many information, just a little information to be able to answer questions. But these are two conditions. You also have to be familiar with hypothyroid, hyperthyroid in that room. That's the room that we wear. That's the things we should pay attention to. Ready to go to room 4? I hope you are ready because you're mastering concept of NCLEX endocrine review NCLEX, and this will help you master NCLEX endocrine questions in the flawless way for nursing school if you're also having problem in the nursing school. Now, how do we treat this patient? Let's talk about thyroid hormones, which are medications, right? These are medications that we'll use for thyroid conditions. They are called thyroid meds, right? They are very, very important. In the room that you went to, these are the medication they're taking. And so you have to provide some teaching, all right? These room 4 that you went to, they are thyroid medications. This is what they're already taking. So you get to teach them. One of them is taking what? Levothyroxine. This is NCLEX favorite. What do you tell this patient? Take it in the morning. Empty stomach. Okay, nothing in your stomach. And this has to be a lifelong. You can't stop taking it if you're taking levothyroxine. When you stop taking it, and let me know, but you don't stop taking it on your own, let me know. When your heart rate increases, that means I've overshot, right? When you start losing weight, right? Weight loss, that's a problem. Now you're turning into hyperthyroid. That's the problem. You have lost weight. So that's a major problem I should pay attention to. The second guy is what? He taking PTU, or he was taking on methamiozole, and they flip back and forth. What is the major problem with this? Agranulocytosis. So agranulocytosis is key. If you don't know anything at all, know this. Agranulocytosis. That means infection is your priority. Don't worry about anything. Would they tell you about infection? No, they will tell you patient has fever. They tell you patient has sore throat. What? That's a major problem. Let me know. The other thing too is you should have pregnancy. Very, very important, especially methamiozole. So they should not be taking it during the first trimester of pregnancy, but they will need it for pregnancy, but not the first trimester. So those are the things I wanted to teach this patient in that room. Ready for the next room? Let's go to the next room. You went to another room, and what do you see? Oh, patient is like had surgery, for thyroid surgery. He had thyroid surgery because he has hyperthyroid and he needs thyroidectomy. So he had thyroid surgery. What are you going to worry about? This is care, post-op care. This is a perioperative care. And this is what the NCLEX is going to ask you. Know this. I want you to write this down. Write it in the comment and put it down that these are key things I should worry about. These are 4 NCLEX priority I want you to know about. These are prioritization. Know this 4 NCLEX priority. Never forget them. They are key. Know them. This is prioritization. What is that? Stridor, airway. Worry about stridor. That's the key. Worry about bleeding. That's your next thing. That's very, very important. And then hypocalcemia symptoms. The C and the T signs. These are something that NCLEX love to ask you. Pay attention to that. And then the 4th thing, this is very, very important. 4th thing, you have to keep trach kit at bedside. because when you go into emergency, this is something that you have to pay attention to. So hypocalcemia symptoms, bleeding, airway. For NCLEX prioritization questions, they're going to ask you regarding a patient who had thyroidectomy. That's your room, and that's the things you pay attention to. When you receive plan of care, these are the things you have to pay attention to that patient. You walk to the next room, and what is the problem? Patient is worried. There's two patients in the room. They both have different conditions, and they worry. One is not happy. The other one is okay. What is going on? The other one is complaining about tingling, okay, and twitching. It's not happy at all. Followed by what? You have what? The C and the C sign. So positive. C and the T sign. You know them, right? Carpal spasm. When you check the blood pressure, you put a cuff, you tap the fascial, there's spasm going on. These are signs that the NCLEX will ask you. And then patient is on seizure precaution. What do you think is going on with this patient? The next patient, what is the problem? He complained about having kidney stones. He's not happy. He said, I'm tired of these kidney stones. And he said, oh, his bone hurt, right? He's groaning, right? That's the bad problem. It's like me. He has depression. His bone is fragile and they break easily. And he has bradycardia. What is going on with this? This patient has what? Hyperthyroidism. Hyperthyroidism. This patient has what? Hyperparathyroidism. And the next patient has what? Hypoparathyroidism. This patient, calcium is low. We have low calcium here and high phosphorus. This patient has high calcium and low phosphorus. So, what do you think we should do for each of them? Different. If you have low calcium, we give you calcium. If you have too much calcium, we give you a bunch of fluid. That's number one. IV fluid, a lot of fluid. Then flush you out. We give you loop diuretic. And then we give you something to block your calcium, which is calcitonin. So once again, if you have tingling, twitching, you have positive toxic signs and trazol signs. Those are the T and C signs, signs of what? Hypocalcemia, and you're on seizure precaution. Most likely you have hypoparathyroidism. The treatment is low calcium. What? And the treatment is to give you calcium. This will deal with your high phosphorus, and your calcium comes out. But if you have stones, your bones are hurting, and you're groaning, you have depression, and your bones are fragile, bradycardia, you have hyperparathyroidism. What are we going to do? We give you what? Fluid. This is going to drop your high calcium, help with your phosphorus, and block any other calciums available. These are two conditions you have to be familiar with: hypoparathyroidism and hyperparathyroidism. The difference between them is key for the NCLEX and nursing school. These are conditions you have to know. You have to know everything about this condition. Trust me, no. These little things are provided you. The signs and symptoms, the pharmacology is what the NCLEX is going to ask you. When you see a case study, watch for this. Standalone question, this is what you should worry about. Now, your next room you went to is the most interesting room. I love this room, right? This room, there's also two patients in the room. One of the patient, oh, what did he look? He looked very weak. Weak patient. His skin is bronze. He may have some vitiligo skins also. What do you think is going on? and he looked dehydrated. That's this patient. What do you think is going on with this patient? What would you tell this patient is suffering from? And what can I do for you? What can I do for you? Well, this patient, he said what? I need to be in one room. And so they brought me into that room and they took the other guy in the other room. So I'm now alone. Initially, we're together. I'm now alone. Why? Because I have risks of infection. What is the problem? Hey, they told me my glucose is low. And then I'm dehydrated because I have low sodium. And I'm losing water. That's why I'm dehydrated. But my potassium is very high. So they told me not to eat the fast, which is what? Fish, avocado, strawberry, and tomatoes. So that's what they told me. I can't eat some tomatoes because it's going to increase my potassium. And what did they tell me? Well, I need to take steroid for life. If I'm going to have surgery, what do? Increase the dose, twice the dose. If I get sick, increase the dose, twice the dose. I should avoid stress as much as possible. And I should do what? What would I do? Make sure I get my immunization, no matter what. What is going on with this patient? This is what we call what? Addison disease. And these patients are the teaching you provide for them. Addison disease. You provide all this teaching to them, you let them know. And then you got to tell them, if you stop taking your medication, steroid, or you're going to have surgery, you don't increase it, you have infection, you don't take more medication, what is going to happen? Your blood pressure will be severely low blood pressure. You're going to be in shock. You have tachycardia, your heart rate up. Your potassium will be way up. Your sodium will be what? Way low. Your glucose will be way low. And you have to be admitted to the ICU. I need to give you IV medication, which is steroid, immediately to take care of, which is what? Fluorocortisol. I need to give you steroid and aldosterone all together. Otherwise, you're going to get sick or you die. This is what are the signs and symptoms of patient with what? Addison crisis. Know this as soon as possible, because these are high yield information you're going to see on the NCLEX. These shows up all the time, and that is what? Addison disease, and how to treat them. These are the signs and symptoms you may see. Classic Addison. Remember, they have abdominal pain also. And after you finish seeing this patient, you went to another room. They said, hey, what is going on? Let me go see what is going on with the other patient. So you went to the other patient, you went to the room. The client has what? Moon face. Wow. He has buffalo hump. He says he's been gaining weight. He doesn't like that. You check the abdomen, he has abdominal striae. What do you think is going on? Write your answer down and let me know in the comment. Let me know, what do you think? Moon face, buffalo hump, weight gain, abdominal striae. What do you think? And they told the patient, well, hey, you too, you have risks of infection. The patient also has cataract issue. What is the problem? Osteoporosis. Oh my God. He said, I'm not happy about it. All these conditions, and I have ulceration. This is the problem. What is going on with that problem? Hey. And they told me my cortisol is too high. That's why all this is happening. I need it to stop. So high cortisol level. That means my steroid is too high. Therefore, I have high glucose. And then my sodium is also too high. This is all causing my problem, too high. But my potassium is low. So I need to eat a lot of potassium, rich food. So you can eat fast, but Addison shouldn't eat fast. Eat fast. Okay. And they said I'm immunocompromised. And so I can get infection. So I need to get immunization also. What is that? This is Cushing problem. You have Cushing syndrome or disease, depending on where the origin is coming from. So what you monitor for? Infection, right? It's a very, very infection. They should limit their sodium. They should do exercise so that they can lose weight. And they should never stop taking their steroid immediately if they're taking steroid. If they're not taking steroid, then they may need some surgery. But if you're taking steroid, don't stop it abruptly. That's key. Do not abruptly stop it. You can taper it. Okay, we can taper it if we have to stop it, but never, 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 never stop it abruptly, because if you do that, you become an Addison patient and you go into crisis. This is what the NCLEX is going to give you. These are classic symptoms you have to be familiar with. In a very short form, I've given you the difference between Addison and what? Cushing. And this is the thing they may try to trip you, but this video is going to make it easy, as I've told you, I promise you, as you walk through the halls of endocrine unit. Now, hey, you're so happy and you went to the other room, you said, now I got it. I get all the endocrine condition. And the next room you went to, the patient said, oh my God, the nurse, help me. I'm drowning. I'm drowning in water. I'm drowning in my own water. Why? I'm so fluid overloaded. What is going on? They told me I have too much water. I need to get rid of it. So they restricting me, restricting fluid. They say you can't drink any more water. They say my sodium is too low. And so they put me in what? In seizure precaution, right? The bed rails are up, right? And then I'm on my side. They're monitoring my neurological status. I have no pee for a while, so no low urine output. And my urine smell like pungent, very smelly urine. Oh my God. Doctor, can you help me? They checked my urine specific gravity is greater than 1.031. That's the specific gravity. It's too high. And they said, well, we need to figure out. They did some lab. They said my ADH is too high. I'm making too much that my body does not need. What do you think is going on with this patient? This is SIADH, syndrome of inappropriate ADH secretion. And the patient asks you, how can I fix this? Nurse, help me. And you know from your endocrine, you master your endocrine pharmacology. You know how to take care of this patient. He said, the doctors are right. We should continue what? Fluid restriction. And since your sodium is too low, we may have to give you 3% normal saline to help with that, to increase that hypertonic. And we have to block the ADH. So we give you democlocycline, or we give you medication with the last name as Vactans. This is the way we can cure you. Otherwise, we will be in trouble for a while. Oh, is that so? Patient is so happy. He said, I'm not going to drink anymore, but please solve this drowning, because I'm drowning in myself. SIADH. And if you don't have anything that was secreting all these things, probably we got to get a chest x-ray. Why? Because you can have small cell lung cancer. Classic NCLEX source of what? SIADH. Please know this. Notice this is a Dr. NCLEX representing this fact in a straightforward manner, lively, relatable so that you can understand, you don't memorize it. Welcome to our crash course, Adapting Class Way. Now, you went to the next room and said, well, if this patient is suffering from this, I'm going to flip it. I'm going to flip it. You went to the room. He said, everything is dry. It's like a desert. It's like a desert. I live in the desert. Why? Even though everything is dry, I'm peeing like crap. My urine output is too high. I can't stop going to the bathroom. I feel dry inside. They told me my ADH is too low. That's why I'm losing all my water. Eight liters a day, right? That's like unbearable. I spend my time in the bathroom. My sodium is so high. My tongue is sticky, right? Sticky tongue. Why? Because you have hypernatremia. They say I got to bring it down. My urine is so, it look like water. I can drink it myself. So low, what? Urine specific gravity. I can drink the urine. It doesn't look like urine. It look like water. So what can I do? And I keep on trying to drink. It's not helping. Yes, because your sodium is too high. So what are we going to do? We're going to give you some fluid. The fluid we're going to give you hypotonic fluid, like free water. Let you drink a lot of free water, or maybe 0.45% normal saline. This is fluid electrolytes. You need fluid electrolyte. Check out that class video and make this simplicity. Like I told you, this channel, the area of simplicity. That's all we do. Simple, straightforward, no beating around the bush. This is what we're going to give you. They ask, oh, what kind of pharmacology are you going to give me? Endocrine pharmacology. Well, if you need ADH, I can give it to you, but I can't give you the same form of ADH. I'm going to give you desmopressin. It's a form of ADH. And these, when we give it to you, you can take it by mouth. You can take it through the nose. We can give you an injection. You may get a headache if you go through your nose. And if your nose is stuffy, let me know. But if I give it to you, I need to monitor your urine output so that when your urine output decrease, you don't become like the other guy in the room who have what? SIDH. And this is your room. You finish the room, you high five each other. And then you went in the last room, room 11. You said, oh, these guys, it's like you never seen them before. Two clients, they sitting side by side, two clients. So what is going on with these guys? They have large hands. The feet is large. Their jaw is large. What is going on? Every organ, you listen to them, you can feel your heart. It's like cardiomegaly. It's so big. What is going on? They have cardiomyopathy. Big, big, big giant. The other guys look like a giant. He's so big, like he's tall stature, right? And then he's very young, so he has early growth. He's like 18 years old, but what is going on? How do you look like 40 years old and you that big? This is what we call acromegaly. And he's giant. This is a giant problem, right? Gigantism. That is the issue. All of them is excess growth hormone. So watch for that kind of questions. Excess growth hormone. And then this is what is leading to that condition. Acromegaly, this is usually an older patient. That patient was about 45-year-old, and this guy was young. He's like 15 years old. This is what is the problem. How do you treat it? Pharmacology. Pharmacology is what? Treatment is to block the growth hormone. What we use is octreotide. Know this. And they may need surgery to help with the pituitary, removal of the pituitary gland, because that's where it mostly is located. Or they may need some radiation. But this is the patient you've seen. You've done a good job. You cure all of these patients, and you're about to leave for your shift, and they say, don't go. We have two people we got to deal with. Two people we got to deal with, and they are also having issue. They are in the same room, and they worry. That's your last room. They worry. They say, well, doctor, fix me, because both of them, your blood pressure is too high. One is because of aldosterone. His sodium is way up. Potassium is low. And he has hypertension. He's not happy. That's his problem. The other guy, he said, well, my blood pressure is high, but that's not the only problem. So I have severe hypertension. But what is my hypertension? It's episodic. It's different from the other guy who is always blood pressure is very high. This is episodic hypertension. It's different from that guy. Put down your answer in the comment and let me show you. I'm showing you signs and symptoms. This helps you with case study. I do not give you the initial condition. I give you signs and symptoms. And if you know these buzzwords, I call them buzzwords, you can write down the condition. You'll be able to identify the condition. This is the way I teach. Buzzwords, and then you can figure out. A severe hypertension, that is hypothetical, and then patient is also tachycardia. He's sweaty too much. What do you think? He has palpitation. And he has what? Headache. Right? This is condition that you have to know. Condition that you have to know. And then the precaution on the wall, he said, do not palpate what? The CVA area, costovertebral area, costovertebral area. Do not palpate, or the abdomen area. Do not palpate, because if you palpate, you're going to release catecholamine. This is what you're going to release, and that I'm going to get sick. If I'm a child, this will be called Worm's tumor. If I'm an adult, this is called pheochromocytoma. You see the point? Hypertension, tachycardia, sweating, palpitation, headache, right? And if it's severe, you should not palpate my CVA area, costovertebral area. Do not palpate my abdomen. If I'm a kid, this may be Worm's tumor. If I'm an adult, it's a pheochromocytoma. And if I need treatment, I need an alpha blocker first before a beta blocker. Otherwise, I'm going to have severe hypertension. And then I need a bunch of fluid because I'm dehydrated. This is what? Pheochromocytoma and a Worm's tumor. But for this guy, his problem is Crohn's. It's because he has too much aldosterone. This is Crohn's disease or syndrome. And the treatment is to do what? Block aldosterone. One medication, block aldosterone. It's called Addison. And what is Addison? It's called what? Spironolactone. You see, you know it. This is pharmacology, cardiac pharmacology. Coming through endocrine. These are your 12 patients. You just walk through the entire endocrine unit, and you have understood these 12 patients. You understand endocrine pharmacology. You understand endocrine concept, SIADH, thyroid problem, hyperthyroidism. You know parathyroid problem, hypoparathyroidism, and then associated symptoms. You know adrenal pathology, right? You know Crohn's, pheochromocytoma, everything about endocrine, including pharmacology, management, sick day, nursing care, everything. Crash course in the very short form. If you watch this video and you watch it multiple times and you take notes and you go take a question and cue back, you go and answer question and you get it wrong, I would like to know. Put it down in the comment, come back and say, I got this question wrong, and I will answer you why. Take care of yourself. Thank you for watching, and good luck adapting class. And if this video helped you, put a little bit of comment and say hashtag I watch it, and then subscribe for more content like that. Take care of yourself, and bye.